Good morning. I think we'll get started. My name is Steve Taylor, and I'm here today to introduce both this general topic of our junior faculty grand rounds. We try to have twice a year an opportunity for junior faculty to present their work and to kind of get the department, give the department a chance to kind of find out what they're doing. We often don't find out we don't know what people are doing sometimes in the office next door until we sometimes go away to a meeting or something. So we try to make sure that for our junior faculty they can have the opportunity to share some of their research and let people know what they're doing. They also get the opportunity, of course, to do a presentation. So we split the grand rounds into two or double up the session. And today I'm really pleased that we have Dr. Donovan Most, okay, it's a German pronunciation, and Dr. Ivy Cho. And I'm going to introduce Dr. Cho. I'm very delighted to introduce Dr. Cho. She got her degree at the University of Hong Kong, a master's in philosophy, and started her psychiatric research career, and then came to Michigan, where she started to actually work in my lab, first as a research assistant, and then went on to enter our clinical psychology program here in the Department of Psychology, where her advisor was Dr. Patty Delden, also a member of our department, and has, after doing a postdoc in the clinical psych program here, has now moved on to a faculty position where she is currently an assistant professor. I will let her tell you about her research, since that's the whole point of this. As I said, I'm very delighted that, particularly since I've worked with Ivy over these few years, and it's nice to really have her on the faculty now. And I hope that the rest of you can kind of hear about what she's doing and have a good sense of what her research is. So, Dr. Cho.
Thanks, Steve. Can you guys hear me okay? I think this is working, right? Okay. So today I'm going to tell you about my research program which focuses on eye gaze perception in the schizophrenia-bipolar psychosis spectrum. So first, I'll let you know why I'm interested in eye gaze perception and why we should care about eye gaze perception in schizophrenia and the schizophrenia-bipolar psychosis spectrum. And then I'll tell you a bit more about the behavioral studies that I have done in the schizophrenia and schizophrenia-bipolar psychosis spectrum, and a little bit of pilot data in first episode psychosis. I've also examined eye gaze perception in schizophrenia and bipolar disorder using ERP, but I'm not going to talk about that today due to the time constraint. I want to focus more on the current fMRI studies in this area. So, as we know, schizophrenia is a severe chronic mental illness, and it affects 1% of the population. The most prominent symptoms of schizophrenia include hallucinations, delusions, and disorganization. However, what is more problematic with schizophrenia really relates to the functional impairment associated with the disorder. According to the World Health Organization, it's among the top 10 most debilitating diseases in the world. And functional impairment in schizophrenia also have very limited response to medication treatment. So this really illustrates that we have an urgent need for better intervention to improve the functional outcome in this disorder. So in order to do this, we have to first understand the mechanisms of social dysfunctions in the disorder. And then from the knowledge of the mechanism, then we can devise more targeted intervention and hopefully can evaluate the new intervention in future clinical trials. And my current work focuses on the first step, understanding the mechanism, and the next two steps will be in my planned future directions. So if you guys are old enough, you will remember these two people. This picture was taken during, I think, the re-election of Bill Clinton. So it was before the relationship between the two became public. But from the way they were looking at each other, it was pretty obvious in retrospect that there's something going on, right? Okay, so this is a more recent example. So you definitely can tell there's something there. Okay, so these two examples really tell us like the eyes have it, whether for sex scandals or for other more important things. But we like sex scandals more, I guess. So eye gaze direction. Eye gaze is a really important social information. It conveys the attention of the person and communicative intention, and also their mental state. And the ability to use eye gaze information to guide behavior develops very early on in life, during infancy actually, and is a basic building block of social cognition. And we know that there are a wide range of social cognitive deficits in schizophrenia, but from the literature, it's quite unclear whether the deficits include gaze perception. And we still don't know whether that is related to the functional outcome as well. So I'm going to tell you a bit more about the behavioral studies in gaze perception that we have done. In a recent study that we have published, we look at eye contact perception in schizophrenia and how it's related to the broader socio-emotional functioning in the disorder. We studied 26 people with schizophrenia or schizoaffective disorder and 23 healthy controls. They were well matched for age, sex, and parental education. We, instead of picking some arbitrary gaze direction, we actually used a psychophysics approach to look at the gaze perception as a function of the eye contact signal strength, from all the way from averted eye gaze angles to direct eye gaze angle. Can you see this clearly? Does it show? Yeah, you can see that, right? From on the left is all direct, like averted. On the right is more direct. So the task was really simple. So the subject has to just push a button to tell us whether they feel that the face is looking at them or not. And they saw a lot of these pictures in different actors in a pseudo-randomized order. So after they have responded to, I think, probably more than 500 of these faces, we can, for each subject, we can actually plot their percentage of yes response, like yes looking at me response, against the eye contact signal string. And it actually looks very beautifully. It shows a very beautiful logistic curve in this way. What I'm interested in, one of the measures is the slope of this response curve at 50% of eye contact endorsement rate. When you think about it, when the person endorses eye contact less than 50%, it means mostly no, right? But when it's more than 50, that is mostly yes. So the change of category really occurs at the 50% of endorsement rate. And I want to see how rapid this change is to index the gaze perception. So it turns out that people with schizophrenia do have a more shallow slope. It means that the rate of change is much slower than healthy controls. And the graph on the left is a prototypical curve. It's not a group data. So it kind of like illustrates what it looks like in schizophrenia. And the right is the group data of the slope. So what it means is that the eye contact discrimination in schizophrenia is much less dichotomous than healthy controls. And they tend to perceive eye contact only when the gaze is ambiguous. So it's a pretty good piece of evidence that it's not a generalized deficit, but it really is pretty specific. When we look at the functional correlate, we have a measure of emotional intelligence. We use the measure called MSCID, and it's a performance-based measure of emotional intelligence. So we found that in people with schizophrenia, eye gaze perception correlated pretty strongly with MSCID performance. However, when we look at the correlations between the basic condition like attention, memory, verbal fluency, executive function, etc. We also find some significant correlation with both gaze perception and the broader socio-emotional emotional functioning. So, is this relationship between gaze perception and emotional intelligence due to a general deficit, right? It's a very fair question to ask. In order to address this question, we ran a hierarchical regression analysis. In the first step, we entered basic cognition in the regression model. So it significantly explained 32% of the emotional intelligence. In the second step, we enter gaze perception as a predictor. And so in addition to basic cognition, gaze perception actually explains an extra 16% of variance in emotional intelligence. So it provides another piece of evidence that it's actually beyond a general deficit problem. And it's quite interesting when we look at the relationship between gaze perception and emotional intelligence. We saw the same relationship in healthy controls and schizophrenia. It's just that in schizophrenia, they just perform worse in both domains. So it says a little bit like eye gaze perception is really important to our general socio-emotional functioning, whether you have schizophrenia or not. So to summarize this study, we found eye gaze perception abnormality in schizophrenia, and that we also show that is quite important to broader socio-emotional functioning. So the next question that we're interested in is the mechanism, right? So we know that there are a lot of reports documenting deficit in basic visual perception in schizophrenia. Then it's very reasonable to speculate if the abnormal eye gaze perception in schizophrenia can be explained by more basic visual perceptual problems. Mm-hmm.
Confuse a little bit the language, like when we say the variance can be explained by, it almost carries with it explanatory power rather than speaking of association. And from that, it's easy to say this is important for that one.
Mm-hmm.
Right now, could it go the other way? I mean, is the association that you are talking about, that you have found in the regression, is really directionality to it, or even more causality, or at this point we don't have sufficient information to say anything?
Right, yeah. Yeah, so that's a good point. And this data right now, at least with the behavioral data, only provide the correlational nature of the data. So we don't know about the direction, and that's actually what I will try to address with the fMRI study. So I'm going to talk about that later. So, okay, go back to the mechanism question is that if deficits in basic visual perception can explain the higher level eye gaze perceptual problem in schizophrenia. And in a recent study, we tried to look at the role of visual integration in this area. So we look at the construct of visual integration. It means that it's the ability to integrate individual local visual elements to form a more holistic representation. And it is critical for some function, for example, object recognition and Gestalt grouping. And we use a contour integration task. So this is what the stimulus of the task looks like. You can see a lot of Gabor elements in here, right? And some of them actually form a contour, a round shape. Can you see that? Yeah. And it's pretty easy, right? It's over here. Because the jitter degree of the elements that line up to form the contour is 0. It means that they line up perfectly. So when we manipulate the jitter degree, make it not line up as nice, it's a little bit more difficult, right? But you can still sort of see it, right? It's over here. So when we make it even, the jitter degree even higher, then it's much more difficult now, right? It probably takes you more time, or you don't see it at all. and it's over here. Okay, so, and we use a 3 up, 1 down staircase algorithm to look at visual integration. So it means that you have to make 3 correct responses to go up 1 difficulty level, and if you make 1 mistake, then you will go down 1 difficulty level. Sort of like GRE, if you have taken it, right? It's adaptive, depending on your responses. So after 12 performance reversal, then we terminate the task and we calculate the threshold. The threshold really means that the difficulty level at which the person can perform reliably well. And in this instance, the equivalence is 75% of the time. So we looked at the visual integration in schizophrenia and healthy control, and we did indeed find significant differences between the 2 groups. And so we want to look at if visual integration is related to higher level social cognition, including eye gaze perception and emotional intelligence. And we did find significant differences in our schizophrenia group. So this study shows that yes, it seems like visual perceptual deficits seem to play a role in social cognition in schizophrenia. Another question that we have not quite addressed is that, okay, so there's perceptual deficits in schizophrenia, and that's related to the eye contact perception. Is it specific to schizophrenia, or is it a function of severity of psychopathology? So we try to answer this question by looking at the schizophrenia-bipolar psychosis spectrum. And we used the same eye contact perception task, and we collected more data in a group of bipolar disorder. And we also ran a few more subjects with schizophrenia and schizoaffective disorder and split them into 2 groups. And we also got 10 first episode psychosis patients. So this showed that I line them up in terms of their performance level. So healthy controls perform the best, and second is bipolar disorder, and then schizophrenia. And first episode, psychosis, actually it has almost the same impairment as schizophrenia. And surprisingly, schizoaffective actually performed the worst. When you look at the post-hoc statistics, it's illustrated at the bottom, the Tukey post-hoc test. So it means that group 1, from healthy control all the way to FEP, they are not significantly different. And group 2, from bipolar disorder to schizoaffective, all the patient groups, they're actually not significantly different from each other. So it actually provides pretty good evidence that maybe eye gaze perception varies as a function of the schizophrenia bipolar psychosis spectrum. When we look at the relationship between eye gaze perception and emotional intelligence, this finding is pretty interesting because in healthy control and schizoaffective and schizophrenia, we find the exact same relationship between these 2 variables. But in bipolar disorder, there's absolutely nothing there. So I think if Melvin here is not here, he would be pretty happy to see this result, I think. It may suggest there's some different or even a compensatory mechanism going on in bipolar disorder, even though they have some problems with eye gaze perception, but it doesn't seem to really affect the emotional intelligence. We also look at the visual integration function in the schizobipolar spectrum, and we find we had similar finding. Again, bipolar disorder seemed to show some impairment, but at the same time, it's not to the extent that is shown in schizophrenia and schizoaffective disorder. And when we look at the relationship between visual integration and eye contact perception, this is slightly different. We don't find any relationship in healthy controls, but in schizophrenia and schizoaffective disorder, there seems to be still a positive correlation. And in bipolar disorder, we don't quite know yet. It's not significantly different from 0. And when we combine the schiz group, it's significant. So to summarize this study, seems like the gaze perception abnormality may not be specific to schizophrenia. It may be a function of psychopathology. And there might be some differential mechanism in bipolar disorder and schizophrenia versus schizophrenia or schizoaffective disorder. So next, I'm going to talk about my current fMRI study in this area. So it's sort of go back to Israel's question earlier. Those are correlation data that we just saw, right? So we don't know about the mechanism really. Like, is it bottom up, right? If we have problems with more basic visual perception, we will expect that the problem will propagate through the perceptual system, right? To affect our higher level of functioning. But at the same time, there's a lot of documentation of prefrontal cortex deficits in schizophrenia. So it's reasonable to ask, like, maybe because there's some failure to modulate the more lower level process, right? And that's why it propagates through. Sidetrack a little bit. Have you guys seen this picture last week? Right? It broke the internet, right? So the debate is like, do you see gold and white or black and blue? Can I have a show of hand of like gold and white? Lots of people. Black and blue. So people. Okay. Yeah. So some people see it actually both ways. Yeah. It's actually
gold. I see blue and gold. I'm sorry.
Anyway, the dress also broke a colleague. So Chandra was saying this in great distress. Like, I swear to God, I saw gold and white in the morning and then black and blue in the afternoon. I was so confused that they changed the picture and everyone was messing with me. So don't tell him. I don't think he's here. Don't tell him I told you guys this. This really illustrates that our perception really depends on the interpretation of what is going on. So there's a New York Times article last Friday to try to explain this phenomenon. Like, if your brain interprets that the dress is in shadow, then your brain will adjust the lighting and perceive it as gold and white. But if you feel that the dress is actually in bright light, your brain will actually perceive it as black and blue. So this example illustrates that visual perception is not an entirely data-driven process. It is modulated by our knowledge and our expectation. So now go back to this process, right? So if there's some problems in prefrontal cortex function in schizophrenia, then we will expect that maybe they fail to properly modulate the function in the visual cortex, and therefore there's problems propagate through the system. Or maybe both, right? Some of the visual perceptual deficits in schizophrenia actually is pretty hard to fully explain by higher level functional deficits. So there may be both deficits going on and lead to the problems in social cognition in schizophrenia. So my current fMRI study, I try to use a brain network approach to address the mechanism question. The goal is to identify the neural mechanism underlying altered gaze perception in the schizophrenia-bipolar spectrum and try to identify the target for future intervention, especially cognitive training. And so the future direction will help me to use this information to develop very targeted cognitive training intervention. Just tell you a little bit about like what I'm doing with the fMRI study. So the first step, I collect functional MRI MRI time series data during gaze perception. So I adopted the gaze perception paradigm to fMRI and to try to isolate the brain responses that are specific to eye gaze perception. So subjects, for people who are not familiar with fMRI, I'll explain a little bit what's going on. So this is the basic design. On the top, so in one box they will see some pictures that they just need to determine whether they're looking at them or not, and and then there's some resting fixation. They just do nothing but look at the plus sign, not cross, right? And in the gender block, they actually look at the same facial stimulus, but what they do is different. They just need to determine whether it's male or female. And the next step is to apply dynamic causal modeling to look at the brain responses. So DCM can help us to model brain response to the stimulus input. In this case, it's the faces. And it can also model the influence of the psychological manipulation, and in this case, it's attending to gaze versus gender on the connectivity between brain regions. And the most powerful thing is to model directional influences of one brain region on another, and we call that effective connectivity in this case. And so after building the models, we can assess group differences in all these three areas, including stimulus input, the influence of psychological manipulation, and more importantly, the effective connectivity between the clinical groups. So right now I have collected some pilot data in 12 healthy controls, and this is the contrast between eye gaze perception and gender identification. So it looks like that the test is doing what it's supposed to do. It activates more the occipital gyrus and also the supramarginal gyrus, which is related to mentalizing, and the salient network, including the anterior insula during gaze perception. And we are collecting patient data. We have got 10 bipolar data and 10 schizoaffective and 6 schizophrenia, and more are coming. And we will expand the sample size to 15 each for my KL2 award, and we'll plan to expand it further with my submitted K23 project. So to conclude, there indeed is abnormal eye gaze perception in schizophrenia, and which is characterized by over-perception of eye contact with ambiguous gaze and less dichotomous discrimination. And it is associated with poor social-emotional functioning. And it seems like early visual processing deficits plays an important role in this process. And it may vary across the schizobipolar spectrum, and there may be differential mechanism involved in schizophrenia and bipolar disorder. So an investigation, future investigation of the neural mechanism would be a promising avenue to help us design better treatment. So I want to thank the people who have helped me to put this together and conduct this study, including Steve Taylor, Pat Dowden, Melvin McGinnis, and Vicki Allen Ward, and also the study coordinators of the Psychosis and the bipolar team, Bea Yao, Laura Scher, and Gloria Harrington, and the graduate students Savannah, Tyler, and Erica, who have done a lot in data collection and clinical assessments, and also Dakota Martin, a Europe student helping us to do screening. That's not him, it's Brad Pitt, but yeah, I don't have a picture of him, so I figured nobody will be offended by Brad Pitt. Okay, so thank you very much.
Thank you, Ivy. Two questions. I may have missed it, did you present the averted gaze contour for bipolar subjects compared to those with schizophrenia or healthy controls? Is it different for them?
Yes, let's go back. You mean the more basic visual integration?
The first
Oh, the
set
eye
of data.
gaze.
The eye gaze. I don't recall
Yeah.
how bipolar subjects looked on that.
Yeah, so let's go back. Yeah, it's this slide. Yeah, so bipolar perform worse than healthy control, but not as bad as
But in terms of the
schizophrenia.
contour, I mean, is the contour the same as well?
The contour, it's actually pretty similar. Yeah,
Pretty similar.
yeah, they are kind of in the middle. Yeah.
Okay. I mean, do they have the perception that everybody's looking at them all the time? Or I guess I'm trying to understand the difference that you found, or how you think about the difference between bipolar and schizophrenic subjects.
And in terms of what it means.
Yeah.
Yeah. So what we are looking at is the. Let's go back to this slide.
You didn't. Yeah. So that's.
Yeah. So this measure is actually the slope of the response curve, right? So it indexes how rapid the change from no not looking at me to yes looking at me. So it kind of like index how much certainty or uncertainty given a small change of gaze direction. So seems like bipolar disorder, they are a bit more sensitive than schizophrenia, but not as sensitive as healthy people.
And can you say a word about symptoms?
Mm-hmm.
So are these folks psychotic, not psychotic? I mean, what's your level of symptoms?
That's a good question. So with the bipolar folks, I think, let me try to remember, we deliberately recruited half and half with psychosis and without a history of psychosis. I don't think we find any differences in terms of that. So eventually, that's why we decided to group them together. Yeah. Brian?
Is gaze perception and the contour integration, are those skills that can be learned? I mean, can people improve over time? Just say healthy people.
Mm-hmm.
Is there a learning aspect to it? And then the second question is that something that you could anticipate being like an intervention?
That's a great question. For the visual integration, right, and there has been actually a few studies showing that it might be a changeable process. In schizophrenia who are deaf, like people who are deaf with schizophrenia, they actually have better visual integration. Because when you imagine that, right, with your deaf, all you can rely on is your visual perception, right? So it seems like with more training, then they actually perform better than their hearing counterparts. So that gives us some evidence that maybe that's changeable, and even with in people with schizophrenia. So that might actually inform us how we can intervene in the future. With eye gaze perception, I don't know, I'm not aware of any data. Maybe people in the autism spectrum research can inform us more. I think that's been done quite a bit in that area.
Do you have a sense why would it be improving? I mean, you're saying intervention, but that assumes that somehow interferes or changes the process of disease or of anything, of psychopathology.
At least for eye gaze perception, there's kind of in principle.
Well, that's what I'm asking.
You could
So
imagine that being helpful.
That's the question, right?
Yeah.
Could be, is it a marker? Do you see that as a marker, or do you see that as a mechanism? Do you think there is actually a link between that and the pathophysiological process, or symptom generation, or any kind, or chronicity, whatever?
Or functional, yeah.
Whatever you think that is meaningful for the disease before one says, let's intervene. What's your
Well,
thought?
I think the thing is that it's because gaze perception is related to the border functioning, right? So you would think that if you intervene, then it will make the border functioning better. So that's the hope, but we have no data on that.
Let's go the other way. Right?
Mm-hmm.
Can I ask you, does the eye gaze perception problem, is it related to the negative symptoms of schizophrenia?
You are smart. We actually did find a correlation in the abnormal paper. We did find an association with worse negative symptoms. And initially, we thought that it would be related to more like positive or paranoid symptoms, right? But we did not find that. Maybe because like our population was just like more pretty stable and have very little positive symptoms left. But we did find a positive correlation with negative symptoms. Yeah. Yes?
I didn't know whether you were looking at me. I guess that means something, right? So, I have the experience of working with very troubled folks, and it seems to me that this particular correlation, the eye gaze, it always improves as the relationship I have with the patient improves. So it seems to be a reflection of whether I'm doing good work or whether they like my jokes, one of the two. But it looks like that's what you'd look for in treatment, right? I mean, a relationship that may improve over time.
Yeah, and I do have that observation clinically. I have a few patients with schizophrenia or schizoaffective disorder. Like the first time I met with them, they would just look away. But as we work together more and they develop trust in me, then their gaze, eye contact actually, normalize, over time. So yeah, I think there's actually, that process going on, and maybe the top-down process is also very important.
Good. Join me in thanking Ivy again.